Okay, how to take focused history from someone who is presenting with the chief complaint or concerns of being unable to conceive. Now, uh, infertility could be from either partner, and it could be because of the lack of regular sexual activity. That's why those are the things that we must distinguish from before we start investigating one person or the patient presenting for causes of infertility. We can simply ask them about their sexual intercourse habits. Are they having regular sexual intercourse? If that's yes, then we move on to the next thing, which is to ask if any of them ever had children from a previous relationship or a previous partner. This will narrow down our investigations to either the patient, or we would have to investigate both if both haven't had a child or pregnancy or conception in the past. Now, in cases like the ones that we have here, if someone is presenting with infertility, the first thing that we did was rule out if they're having regular activity, and then rule out whether it's a male related infertility or the female. So if it is the female patient coming in and we already determined that we haven't been able to narrow it down to her or to her partner, next step would be to ask a complete symptom review, quick symptom review you can do with her. Ask about common causes of infertility, ask about acne, weight gain, galactorrhea. This will narrow down our diagnosis to very simple or few investigations, and we would be able to have an answer for the patient. Once you ask the patient about their health history and symptom review, go to the partner's history or male partner's history. Ask about history of arthritis. Ask if they're smoking right now. Ask if they have issue with alcohol or alcohol use disorder. Once that's done, come back to the patient and ask about their gynecological history. In gynecological history, you can ask about their menses, and how the patterns are. Is she having regular menses or not? And then you can ask about STIs or STDs or infections or PIDs. All these causes of infertility in women that may be present in a patient, you can cover them in just a few questions. For example, you ask them, have you had an STI in the past? Yes or no. Have you been diagnosed with pelvic inflammatory disease? Make sure you're asking these questions at least. And then most important is, have you had surgery in the pelvic region in the past? Some patients may have had surgery in the past for unrelated reasons, and now the scarring or adhesion is what is causing the infertility. So this will narrow down our uh, history taking to where we should focus. We can ask about their weight gain, for example. It could be a sign of hypothyroidism. Patient is not gaining weight without eating too much, or patient has weight gain with cold intolerance. We can think of hypothyroidism. Hypothyroidism can then um, cause menstrual irregularities and infertility. Once you go on and ask, once you are done with the gynecological history, move on to the obstetric history. Ask the patient if she had any children. No, it's fine, you can stop there. Or if they had any children in the past, ask about how they did after the delivery. For example, some women may have postpartum hemorrhage, and they can have Sheehan syndrome, they can have intrauterine adhesions or Asherman's, etc. These can all be ruled out or ruled in based on how thoroughly we take patient history. Once we are done with obstetric history, we just move on to the past medical history, ask about conditions like diabetes, hypothyroidism or hyperthyroidism, endocrine conditions, other endocrine conditions, see if they have anything that could be causing their infertility. Once that's done, you can then move on and ask about family history, specifically family history of conditions that may um, increase her chances of not conceiving. Ask about family history of thyroid illnesses, infertility in any female patient, female or relative, or any aunts, etc. Once that's done, move on to social history, smoking, alcohol, drugs. Ask all about all of them. This will help us in um, determining if they kind of could be the cause of their infertility, or Since for the exam, they want you to think that this is a patient who you will be seeing regularly and following up. So in that case, asking these questions are important in case you help them get pregnant. In those cases, you would have to advise them on what to do about smoking, alcohol, etc. Um, Once you're done that, we will then now moving on to how to take the history of present illness. So first thing first, ask about how long have been they've been trying to. Second, how often do you have intercourse? Third, ask about menses, regular, irregular. Then pain during, at the middle, or after menses. Why we are asking about pain? Because it could be an indicator of ovulation or anovulatory menstrual cycles. If women do not have any pain in their painless periods, usually mean there is no ovulation happening. So period with some discomfort should be there, especially in the middle part that we call metal schmers. Sometimes they can experience breast tenderness or breast engorgement or pain in the breast too. Ask about that. Then ask about bleeding during or after sexual intercourse. Sometimes it could be a sign of endometriosis or another structure abnormality. Ask about weight gain or weight loss. Ask about hair growth. We are trying to rule out the common causes of infertility in the female patient that's presenting to us. Now, once you're done with those general questions, ask about vaginal discharge. If patient says yes, follow it up with the structure of coca B, color, order, consistency, amount, and blood in it. This will give you an idea if the patient has a PID or another infection or any reason why they couldn't be pregnant. Ask about mass or swelling. Sometimes patients may have some types of cancers that are uh, causing irregularity in their menses and making it hard for their to get pregnant. Ask about pain unrelated to the one that we would expect during the middle part of period. Chronic abdominal pain or pelvic pain, it could be a sign of something chronic going on. Could be because the patient has some chronic infections in the pelvic area or chronic PID that has caused excessive scarring and now it's hard for them to conceive. Ask about heat or cold intolerance, which again would point towards hypo or hyperthyroidism. Ask about nipple discharge. For example, if someone has white milky discharge from both nipples without a late part of pregnancy or breastfeeding, it's usually milk, and milk shouldn't be produced by someone who is not pregnant or breastfeeding. So if it is present, then it could be a sign that they have an intracranial tumor, for example, a pituitary adenoma or prolactinoma that's causing them to their body to produce excess amount of prolactin without the stimulus of having a child or nursing a child. Ask about infections, tuberculosis, or other infections that, or especially pelvic inflammatory diseases or pelvic infections. Ask about those infections. They may be a cause of the patient's uh, infertility. Finally, you ask about some of the constitutional symptoms, fever, nausea, vomiting. These can narrow down our differential to just a few versus the vast majority of differentials. So history parting or history of present illness, this will narrow down your diagnosis to two, three, or four causes. Now, once we have narrowed down our diagnosis, we move on to the male partner. Male partner, does he have any difficulty during sex? Does he have any sexual problem? Is there any erectile dysfunction? Has he had any pelvic surgery? Has he had any surgery, especially on the uh, genital area or pelvic area? Trauma to that area? Medical conditions, childhood mumps, medications that he's taking, cigarettes, alcohol. These are all some of the causes of male infertility. Ask about sexually transmitted infections. Uh, if there is any, ask about what was done for the treatment and when was it. Ask about stress. Sometimes excessive amount of stress can lower sperm quality. Ask about if they have any kids from past relationships. So this question about past relationship or previous relationship, it should be at the upfront, so to make it easier or to make it narrower for us to question first further. Now, gynecological history. Ask about when did they start to have their period, menarche. How has it been? Normally, we would expect the periods to start anywhere from 11 to 13. It can start all the way up to age 8. Below 8, we consider it then precocious puberty in girls. Now, ask about the regularity. Menses, when they start in the first couple of years, they may be a little irregular and out of place, but then they start to become more regular. um, Ask about the duration of each cycle. Blood, is it light, heavy? Heavy bleeding would give us an indication of whether if there is any fibroids. Sometimes fibroids, especially if they are in the lumen or protruding to the lumen, they can interrupt with um, interfere with conception and make it hard for the patient to get pregnant. Ask about dysmenorrhea. We are asking about dysmenorrhea, dyspareunia, bleeding during sexual activity. All these just to make sure that patient doesn't have endometriosis. Sometimes endometriosis may not be with very specific symptoms. It can come with deep dyspareunia or bleeding during or after sexual intercourse. This is why we ask these questions sometimes. And make sure you're comforting patient every now and then, because these are very sensitive questions and most patients wouldn't be comfortable, especially if they're a younger patient. So make sure you're using, I know these questions are very sensitive, I know these questions are very personal, but we have to make sure we are being thorough and not missing anything. Now, once you have covered their gynecological history, move on to obstetric history. Any children? No, you can stop right there. Yes, ask about gravida, how many times have they been pregnant? Para, how many births? So this will give you an idea whether there could be any issues, any complications from delivery or childbirth that may be causing this current infertility, or it will also point to us that patient is normal and are able to conceive. Maybe the issue is with the male partner, so we can then move on and investigate the male partner in more details. Ask about their deliveries. When were they? Were they at term or preterm? Sometimes women may have cervical insufficiency, which makes it hard for them to carry a pregnancy to term, and they would have recurrent second trimester miscarriages. Ask about abortions, especially abortions that are done in a non-clinical situation or in situations done by non-experts. For example, women not willing to go to a hospital to get abortion and they get it done elsewhere. They can have septic abortion, they can have adhesions. Ask about dilatation and cortege. Dilatation and cortege can make them have adhesions, so that could be a cause that they are not having any luck in getting pregnant again. You also ask about live birth, multiple births. These are all questions that will give us an idea of not only how to manage this infertility complaint, but also help patient in their follow-up when they are pregnant. If they have had any pregnancy, so you must ask about preeclampsia, gestational diabetes, postpartum hemorrhage, things like that. Finally, you ask about ectopic pregnancies in the past. Since if they had one ectopic pregnancy in the past, it's likely for them to get another one. Once you have done obstetric history, ask about past medical history. Do they have any conditions, diabetes, blood pressure, diabetes, hypertension, thyroid illnesses, anything that could be causing their infertility or could be responsible for their symptoms? Ask about medications. Some medications may make it hard for them to conceive. Ask about allergies to medications or food. Ask about surgery, especially surgeries done on the pelvic region. Ask about their STDs or STIs if they had any in the past. And ask about pap test to make sure that they are up to date with their pap smears and they do not have any risk factors for developing cervical cancer and they don't actually have cervical cancer. Ask about depression, anxiety, mental health disorders. Sometimes SSRIs can make it hard for someone to uh, SSRIs can lower libido, and it may be a reason they're not having regular sexual intercourse, and this is why they're not able to conceive. Now, family history. Ask about genetic disorders, pregnancy-related issues, infertility in the family members, especially close family members, sisters, mothers, aunts, etc. Not mothers, sorry, sister, aunts, uh, uh, sisters of aunts, cousins, etc. Ask about if there is issue that's running in the family. It could be something familial. Ask about chronic conditions in the family. Ask about history cancer, history of cancer like cervical cancer, endometrial cancer. And in family history, we also ask about current situation with their spouse. Is their spouse abusive or beating them, or any concerns that we have right now in their relationship? Once that's done, then we move on to social history, smoking, alcohol, recreational drugs, current relationships. And once again, you can ask about abuse and then stressors at home or work. And finally, you ask about support from family members and their partner, and then move on with investigations. So for infertility, once we have taken our history, menstrual cycles, previous pregnancies, OBGYN history, use of contraceptives, lifestyle factors, once we rule some conditions in that we want to investigate the patient for, such as uh, endometriosis, uterine abnormality, cervical issues, ovulatory dysfunction, etc. We will do physical exam and then move on to lab tests. For labs, we do FSH levels and LH levels. We can check estrogen levels, TSH, since hypo and hyperthyroidism both can alter the menstrual cycle and cause issues with fertility. We check prolactin levels if there is any indication, for example, if they have recurrent unexplained headaches and breast discharge, nipple discharge, which is white in color, could be a sign that they have prolactinoma. We can also screen them for STIs and make sure they don't have any of those conditions that could be causing their infertility. Now, imaging, we reserve imaging for uh, patients that we think may have something like ovarian cyst or uterine abnormalities. Now, in that case, preferred uh, imaging modality is transvaginal ultrasound. It um, can see the ovaries clearly, see if there are cysts on the ovaries or if there is any uterine abnormalities. Transvaginal ultrasound will give us sufficient data for that. If we are suspecting that the patient has concerns of fallopian tube patency, we can then do hysterosalpingography, which will give us an idea of how the tubes are and also if there is any abnormality within the uterus. Now, another thing that we would need to do is to assess if they are getting ovulation. We have basal body temperature charting. Patients are educated on how to do their body temperature. On basis of that, we can then predict when their ovulation is expected. And there are some ovulation predictor kits. You can do progesterone levels during the luteal phase or when the ovulation has occurred. Now, before we do all the investigation for the female, if we do not know the male's condition, let's say the male's history is clear, but he hasn't had any previous children. Now we don't know if he is the reason why they are unable to conceive, or if the female patient of ours is the reason why they are unable to conceive. Semen analysis is quick, cheap, it's effective, and it will rule out almost all male related infertility causes. So, semen analysis before doing all the investigations for female would help us narrow down our differentials to just the female patient. We can consider other tests such as genetic testing and anti-Mullerian hormone levels, endometrial biopsy in some cases. But first, we start with the semen analysis, then go with for the female, we do ultrasound, and we can do hormone assay like FSH, LH, estrogen based on our clinical findings. Now, if we go to causes, um, in women, age, once women start going above a certain age, their the number of ovaries that the number of follicles that they have in their ovaries drop, and then it becomes hard for them to conceive. Sometimes chemotherapy, especially chemotherapy of the pelvic area, can cause issues with fertility. um, Dysfunction of ovulation. This is a common cause of infertility in women. Now, another thing would be women who do not have any menses. In those cases, it could be either hypothalamic or ovarian. So, hypothalamic amenorrhea, it's caused by stress, poor nutrition, excessive exercise, or eating disorders. When you see a female, especially athletes who are very athletic, and they appear to have like visible abs, etc. They may experience amenorrhea or menstrual irregularities because of excessive exercise or poor nutrition. Um, in those cases, the infertility could be a reason of doing too much exercise while eating less food than they need. Pituitary causes like prolactinoma, hypopituitarism, etc. They can also be present in some patients. Ovarian causes like ovarian failure, etc. PCOS is a cause of infertility. Ovarian insufficiency. We also can get infertility with some systemic diseases like Turner's, thyroid disorders, Cushing syndrome, renal failure, liver failure, diabetes, etc. Congenital conditions such as Turner's syndrome, gonadal dysgenesis, or gonadotropin deficiencies. These are some of the congenital issues that can cause infertility. Turner syndrome is 45X. They are missing one X chromosome, so they have a specific presentation. They are short in height, they have obesity, and they're infertile. This is a presentation that you may face or you may see in exams for Turner syndrome. Now, other causes of infertility, tubal factors. For example, patient who had a PID, they may have adhesions or scarring in the tubes, fallopian tubes. Surgery, peritonitis, endometriosis, etc. They may cause tubal lumen to either be narrow or completely shut off, so they won't be able to get pregnant. Uterine factors such as congenital abnormalities, bicornate uterus, septate uterus, diethylstilbestrol exposure when the patient was intrauterine, adhesions such as in Asherman syndrome, or fibroids which are submucosal, or polyps. These are some of the uterine factors that can cause infertility. Cervical factors, for example, if a patient has antibodies to sperm, they maybe have hard time getting pregnant. If the pH of the cervical mucus is acidic, it can be hard for the sperm to travel through it, and it would be um, an issue, or they wouldn't be able to conceive as well. Structural problems such as patients who have had cone biopsies done or cryotherapy done on their cervix, they may face issues with conception or getting pregnant. Endometriosis is present in about 15% to 30% of patients experiencing infertility, and in about 30% patients, female patients, infertility is multifactorial. It is not just one issue causing their infertility, it's multiple or cluster of things that are together and causing their infertility. Sometimes we do all the investigations and we don't know why. So those are idiopathic or unknown causes of infertility that's present in about 10 to 15% of patients. Now, moving on to a common cause of infertility in women, it's polycystic ovarian syndrome or PCOS. So PCOS, you can remember it by this acronym here N. Here H would stand for hirsutism, A would be androgen axis, I is infertility, R is in resistance into insulin. AN is again acanthosis nigricans, which is darkening of the skin, especially in the neck or other regions of the body. These are some features of PCOS. For diagnosis of PCOS, we use Rotterdam criteria, and 2 out of 3 symptoms must be present. One of them should be one of them is going to be either oligomenorrhea or amenorrhea or irregular menses for at least 6 months. They would exhibit signs of hyperandrogenism like a deep voice, acne, hirsutism, etc. They may have multiple cysts on their multiple cysts on their ovaries. Um, any 2 of these 3, oligomenorrhea or irregular menses, and hyperandrogenism, polycystic ovaries. Any 2 are present, we can diagnose PCOS in the patient. We do not consider ultrasound very accurate in adolescents because their ovaries may appear to have multiple cysts without actually having cysts due to the rapid growth of follicles at that age. Now, clinically, PCOS presents between 15 and 35 years. Uh, so we wait for 1 to 2 years in adolescents before we call it PCOS. Sometimes adolescents can resemble PCOS. They may develop acne or hirsutism. They may have menstrual irregularity. That's why we wait for up to 2 years to make sure it's just not part of their growing up. Now, they may have abnormal uterine bleeding, hirsutism, infertility, obesity, viralization, or women developing features of men like hair on the face, a lot of acne, deepening of voice, etc. Darkening of skin folds that we call acanthosis nigricans. It indicates that the patient has resistance to insulin. Uh, Remember, in PCOS, insulin resistance can occur in both lean and obese patients. Normally, we expect insulin resistance in someone who's obese, but here it can happen in lean patients too. Now, how we assess or investigate PCOS? First thing is to assess their BMI, height and weight, and based on that, then we can advise on weight loss, etc. Their blood pressure and lipid profile at presentation. We also check for hormones and glucose or A1C levels. So why we're doing all these tests is to make sure that we are identifying that they have any signs of hyperandrogenism or insulin resistance. Sorry. Now, our goal with PCOS investigations is to identify uh, insulin resistance or high levels of insulin despite hyperglycemia, or patient has hyperglycemia and they have high levels of insulin and still their glucose is high. That means that their resistance to insulin. We want to make sure that they are not developing secondary complications of PCOS. That's why we are doing cholesterol and then TSH, prolactin, T4. We are trying to rule out other comorbidities with the PCOS. Now, if someone's fasting sugars are high, or fasting or random sugars are high, and we are suspecting PCOS, then we can follow it up with a oral glucose tolerance test to make sure that they are not diabetic, because 10% of patients with PCOS may become diabetic. We can consider biopsy of endometrium if there is a long-standing long-standing abnormal uterine bleeding or bleeding between two periods to make sure there is no hyperplasia. Since in PCOS, the estrogen, there could be excess of estrogen along with the androgens that could cause issues with that can increase the patient's risk for developing endometrial cancer. On ultrasound, we see multiple follicles or volume of ovary is more than the expected volume. Sometimes they can give a string of pearls or kind of like a single string that has multiple cysts on it. This is how the ovaries may appear. Uh, Treatment. Now, PCOS treatment, mainstay of treatment is dependent on what the patient's goals are. Do they want to get pregnant or do they want symptom relief? If they want to get pregnant, uh, and for symptom relief too, we can start with lifestyle modification. Now, with lifestyle modification, sorry about that. What we do is ask them to exercise regularly and control their diet. This way, they will lose weight. Once they lose about 5 to 10% of body weight, it's very likely for them to be able to conceive, and their symptoms may improve with it. Now, if we want to provide them symptom relief without patients concerned about getting pregnant, we can give them OCPs. Uh, we can give them metformin. Remember, metformin in lifestyle, they are done together for pregnant for patient with PCOS to help with getting pregnant. All right, we can give them tranexamic acid if they are having excess bleeding during menses. Now, how we induce ovulation in these patients, we can try medications such as letrozole, clomiphene, gonadotropins, luteinizing hormone releasing hormone, FSH and metformin. So these are some of the options to induce ovulation when we are trying to help someone with PCOS get pregnant. These will again be together with trying to get them to lose weight, since normal weight would also have good outcomes for the fetus and the patient themselves. All right, so there are some other options like resection of the ovary. Those are done rarely. The surgical treatment is very rarely done for inducing or causing patient to get pregnant. We can try bromocriptine if they have hyperprolactinemia with it. Bromocriptine is a prolactin antagonist, or it blocks the effects of prolactin. Now, for PCOS, how we do symptom relief. So we can use any OCP. These are some of the options that we have: Diane, Yasmin. You can also try Alice, etc. Spironolactone, it can be used for hirsutism. We can mechanically remove hair. We can give them finasteride. We can give them flutamide. We can give them spironolactone. These are all options to help with hirsutism. Now, PCOS comes with some long-term complications. Hyperlipidemia and DM, these would be some of the complications that we would test them for at the time of diagnosis. They can also have endometrial hyperplasia or cancer because of the unopposed estrogen, since they usually are obese with having the menstrual issues. Infertility or subfertility or obesity, sleep apnea. Obesity is a cause of sleep apnea, so they may experience sleep apnea. These are some clinical signs of endocrine imbalance associated with PCOS. They may have menstrual irregularity or amenorrheas. They may experience infertility, hirsutism, obesity, glucose tolerance may be impaired, and DM in about 10% of patients. All right, I hope it clears out PCOS.